Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
James Larkin, hi.
So we were going to do one episode today where we talk about 3 negative adjuvant trials because there are 3 trials with combination immunotherapy up against monotherapy, and none of the combinations seem to outperform monotherapy in that situation. So just felt right to kind of bundle them all together. I guess before we jump into those 3 trials, we'll do a quick fire question. If you had more time to spend on a hobby, which would you choose?
Hobby?
Which hobby?
I don't know. I'd probably do something completely new that I don't get time to at the moment. Like, I don't know, surfing, maybe.
Oh.
That's quite appealing. There'd be a lot of time, though.
That's not the first time you've brought up surfing on this podcast.
Yeah. I mean, maybe it's this whole difficulty of living in London if you grew up somewhere by the sea. I don't know. But that, I mean, it's almost a full-time job surfing anyway, so that's a slightly ridiculous answer. What? It is. It's time consuming anyway. Yeah, I think that's going to be my answer. I'm not going to say gardening or going to the gym. No. Would you want me to say gardening?
No, I'm just curious. What's the hobby you'd like to spend more time on?
Yeah. No, painting.
It feels like you want like a new. I was about to say, it feels like you want a new life. You want you want a fantasy to be able to say, well, if I could, I would go surf. I guess I was thinking more just what's the hobby that you'd like to make more time for?
Yeah.
But maybe it is surfing.
Yeah.
Okay,
so
then the truth is you could. Like, what would be these steps you would take to make more time for it?
Oh, yeah.
Got to Bristol wave pool.
Yeah, I mean, you may as well go to Cornwall or Wales. But yeah, I mean, that's the thing. There's no surf really to speak of in the southeast of England, so you've got a load of travelling to even get to somewhere where there's surf. So it doesn't really work.
So you described a fantasy hobby, basically.
Nothing wrong with
that. Not really. Okay. All right. Do you want to take us through these articles we want to talk about?
Yeah, let's do the references first. So CheckMate 915, Nevo plus minus IPI, and that's JCO. I'm trying to find the year. First author Jeff Weber, 2022, and
online.
then
2023 maybe
in print, and then Relativity 098 is Nature Medicine 2025. First author Georgina Long, so that's nivolumab plus minus relatlimab. And then finally, KeyVibe 010, Lancet Oncology 2026. First author Reinhard Duma. So those are the references. How do you want to do this?
Well, what's the bottom line of all of these studies?
The bottom line is they're all negative for efficacy, I think, and almost always there'll be more toxicity, which is always worth bearing in mind. And actually, I mean, I said that all along I remember, because we did CheckMate 915, and we could talk about epidose in a minute, but it was always obvious that the combination arm was going to have more toxicity than the nivolumab monotherapy arm. you knew that before they do the study. So then the question would be, if the study had been positive, then what's the trade-off between that increased toxicity and the increased efficacy? And then the study wasn't even positive, so that didn't even come up as a question. Go on.
Yeah, I just did this adjuvant sponsored symposium overseas, and one of the things I tried to highlight going through all the data was the toxicity and the discontinuation rate. What are people discontinuing? Georgina had this in her ASCO presentation last year from Relativity 098. I thought it was great that the reasons people discontinued in Relativity 098 on the RELA-NIVO arm is toxicity, whereas the reason most patients would discontinue on the NIVO arm would be progression. But of course, the rates of progression were similar, so it's not to say that one had more or less progression. They had very similar RFS, basically overlapping RFS OS. It was more that, people will stay on monotherapy. They'll stop it because of a recurrence, but combination, you're actually getting stopped early because of toxicity. Does that affect efficacy? Who knows, right? If you're not getting kind of the full, I was about to say supplement, but the full complement of the drug that was intended. So, okay, so talk about IPI dose in CheckMate 915.
Well, I mean, I think you have to go back to the adjuvant IPI EORTC trial, because that's the sort of starting point here.
Ooh,
Exactly.
relic.
Yeah, but important point, right? Because it's a positive trial for DFS, RFS, and
And
OS.
how much, first of all, how long was that regimen?
So basically, it ends up being 3 years if you could manage it. But the important bit, apart from that, is it's 10 milligrams per kilogram. Go on.
So what's the cumulative dose if you did a full 3-year regimen, did you ever do the maths on that?
No, but
I can
do you
tell you.
remember? Yeah, but do you remember that we talked about the possibility of using IP10 for metastatic disease? And I did do the math on that once. If you were giving it Q21 times 4 based on the list price of IP3, and if you got all 4 doses, it ended up being over £1 million. But go
Yeah,
on.
you did the math. I'm just talking about the dose of it. That's 150 milligrams if you do 3 years worth with those 2 years plus of maintenance. Even if you just say, I think on EORTC 18071, the median number of doses was 4. So people just got those 4. That's still 40 milligrams of IPI. What is the CheckMate 915 IPI dosing?
So that is exactly the point. Well, I mean, exactly the point was too strong, but it's 1 milligram per kilogram every 6 weeks, basically. So then,
You
if you
could
wanted to go on,
generously say, yeah, you could generously say 9 doses in a year. You could say 8, but you could say 9 if you count your
yeah,
first one at 0. So 9 doses of 1 milligram is not even 1/4
yeah,
of the EORTC 18071 median number of doses.
yeah,
So already we have a problem. Yeah, go ahead.
well, no, it's an obvious point, isn't it, that we know there's a signal for IPI in adjuvant melanoma. It's just the dosing is close to an order of magnitude different, or half an order of magnitude. And then the next question is, well, does it matter? And then we could talk about IPI dose and efficacy in metastatic disease as per the 3 versus 10 trial. So there is an increment there. Go on.
Well, I was just going to make the point that the ECOG 1609 study was IPI3 versus IPI10 versus high dose interferon. And in that study, IPI3 and IPI10 had overlapping efficacy, different toxicity. So in the final analysis, you see IPI3 against high dose interferon. And the only point to make there is if we use the same sort of maths, median people getting those 4 induction doses, that's 12 milligrams of IPI. And there's also a dose density question. 12 milligrams over the span of 12 weeks, does that look the same as 9 milligrams over the span of 52 weeks, 54
Yeah,
weeks, right?
and I mean, I think these are all unknown, and they're all quite important points. And I mean, I think there's been a fair amount of speculation and discussion about why CheckMate 915 was negative, but at the end of the day, we don't know, and maybe it's ipi
Okay.
dose. But there's no way you could give more ipi, I don't think, in the adjuvant setting, because I mean, a choice had to be made in designing that trial at the beginning. A dose had to be picked, and obviously the limiting factors toxicity. Go on.
Well, but then again, there was an EORTC trial of 10 milligrams, and 10 milligrams of ipi, is it more toxic than ipi-nivo at conventional dosing? One could speculate. But I guess the point is, at the time CheckMate 915 came out, a lot of the fatal flaw could be pointed at the ipi dose. Now we have two more studies that add to the arsenal that combination therapy in the adjuvant setting seems to get you nothing more than anti-PD-1 monotherapy. So rather than maybe get into the weeds of the Relativity 098 and the KeyVibe study, what's the sort of speculation about why would RELA-nivo be effective in metastatic disease, but in microscopic disease, recognizing that we're not treating only exclusively patients with microscopic disease, we're treating patients who are cured as well. So that's a problem, right? We're over-treating in the adjuvant setting by definition. But why does combination therapy work for metastatic disease, but doesn't work in this microscopic setting?
Yeah, and I don't think we know the answer to that. But I thought you were going to talk about neoadjuvant then, actually, interestingly enough.
Well, I have two thoughts, I guess three, now that you put that one in my brain. The one thought is, well, in the adjuvant setting, we don't know who to treat. So we're giving treatment to people who may not need it, in which case they have no recurrences. So that's why recurrences look no different between Nivo mono and Nivo combo. The second thing, whereas in metastatic disease, you're treating people with metastatic disease. Micrometastatic, you don't know who has micrometastatic disease, so you're just blindly treating. The second thing is that in metastatic disease, and I'll bring it to the third point, like in neoadjuvant disease, you have macroscopic tumor. The immune system can see it and sink their teeth into it. The T cells have something to train themselves on because they can see the cancer. And so they can go and bite into it and train themselves on it, right? In micrometastatic disease, if we can't even find the cancer on a scan, we're asking the immune system to be able to go track it down invisibly. Not like targeted therapy where, the key fits into the keyhole nicely. In the microscopic disease, using two drugs doesn't necessarily get you any more advantage in hunting down microscopic disease. I guess that's what we're seeing in these three trials cumulatively.
And
So
doesn't, yeah, I was going to say, so doesn't Nadina and S1801 sort of support that in a way? Because effectively what you're saying there is that you're adding a fairly small amount of ipi actually per Nadina. We could talk about that as well, but if you think about it, it's not that much. And no one's really arguing about the benefit there of adding the ipi. And these are relatively small randomized trials. And, we could endlessly kind of discuss and compare and all that sort of thing, but that increment on the upside with the addition of ipi and neoadjuvant feels real. I hope that's a non-controversial statement.
I think that's real. Again, you've got visible tumor for the ipi to train itself on to help with immune priming. You don't need much of it, and it works. Now, I guess that leads to two questions. So we did back of the envelope math between these three trials, 1,400 patients, 1,100 patients, 1,800 patients. How many patients have we put now through these phase 3 trials of doublet versus mono in the adjuvant? Something like 4,500 patients. Half of them got the monotherapy, that's fine, but we've put now thousands of patients. And to your point, these smaller neoadjuvant trials are saying, look, you can get by with monotherapy or combo in the preoperative setting. I wonder what that does for us. Maybe this is kind of a final question I can ask you. Where does that put us in the adjuvant setting? We've got neoadjuvant therapy we'd like to be able to use. By the way, congratulations on now having it available in the UK, at least the S1801 regimen. let's say 3 years and 2 months after the publication. Congrats.
Yeah.
Way to work at lightning speed. Only joke.
Thank you. It's too kind. I think it's 3 years and 7 months since you
Since the
presented the
presentation.
data in Paris. Actually, I was doing a talk the other day, and neoadjuvant was part of the talk, and I deliberately showed the S1801 slide from ESMO 2022, and then I said a few things about neoadjuvant, and then on the next one I put the NHS England approves April 2026, and I didn't, I didn't labour the point, but I'm labouring it now. Anyway.
But still, England, good job. And actually, kudos to Paul Nathan, who I think really bird dogged that the whole time. So thank you to Paul.
I was right behind him. You know that.
I mean, he must know that. I don't know.
Yeah.
I know that.
Team
anyway, team effort. The point is, where does that put us for adjuvant therapy? Hopefully, people are using neoadjuvant, curing more people, so less people go on to recur. But you're still going to have portions that recur, or you're still going to have portions who are at risk of recurring. So should people get neoadjuvant without adjuvant? Should people get neoadjuvant and adjuvant to try to mop up any of those recurrences? Or should we give neoadjuvant, let people have their surgery, be free for the portion who are going to recur, rather than go blindfolded into microscopic setting with adjuvant therapy? Should we let the small portion that are going to recur so that we can reach for doublet therapy in the metastatic setting?
Yeah, sorry to give a boring answer, but I mean, I think this stuff all needs to be established in trials. The contribution of neoadjuvant versus adjuvant, for example. But I mean, my general comment would be for adjuvant treatment of melanoma with immune checkpoint inhibitors that would topped out, I think, in terms of what you might want to do in the future. But if we see agents, drugs, approaches that aren't immune checkpoint inhibitors, or they're mechanistically complementary, let's just say that, then that doesn't mean that you might not want to do an adjuvant study. And then the other thing is that, I mean, obviously the neoadjuvant data are fantastic and it's a big step forward. But if you think about the patients in the clinic, some patients just don't actually go through the palpable lymph node part of the disease, if you want to call it that. So there's always going to be a question about adjuvant treatment. I don't see that going away, actually. And final point, if you look at the efficacy of these adjuvant treatments, I mean, I only treat melanoma and kidney cancer, i.e. not any of the other diseases where adjuvant treatment is used. But the benefit, I mean, we shouldn't lose sight of that from anti-PD-1 monotherapy and actually BRAF targeted therapy. It's a pretty large level of benefit. We could get into an argument about OS, but I don't think we should. But if you're looking at basically what single agent is a generally well-tolerated treatment, it's a pretty high level of benefit. So it's difficult to see a scenario where I wouldn't want to talk to patients about that in the foreseeable future, actually. There we are. Boring answer, I told you.
No, I think that's a very thoughtful answer, because you're right. In breast cancer, we use adjuvant chemotherapy in many settings for a 50% risk reduction, 50% relative risk reduction, which is often single-digit percentage points. But that can be very meaningful both for a patient, and the provider and the field to have adopted, despite it being chemotherapy and arguably not necessarily as well tolerated as immunotherapy. So why would we necessarily out of hand dismiss adjuvant immunotherapy, which bangs on approximately a 50% risk reduction, maybe 40%, but 50% is fair to say when it's up against observation placebo, maybe more like a 35% risk reduction when it's against an active comparator. But why do we dismiss that out of hand? And it's funny because we really, before that, had a therapy adjuvant interferon that was so highly toxic and had a 10-11% risk reduction, yet we were still so willing to give it. We're still so willing to treat 9, 10, 11 patients to risk reduce 1. And here we have a therapy that's much better tolerated and has a better margin of benefit. So that's a fair point. That's thoughtful in all the ways that you always prove to be. So thanks.
Are we done?
I think so. I don't think it's worth belaboring the fine, hazard ratios and details in these studies, other than to say doublet therapy in immunotherapy in the adjuvant setting, it's not a thing. If somebody is stage 4 resected, that's potentially a go see episode, whatever, Immuned trial. That's its own group of patients. And by the way, they do great with perioperative pembro on the S1801 cohort. So you also could leave it in place, give it perioperative and resect still. But I think doublet's not a thing. Keep going with monotherapy. Keep at least considering monotherapy as a tool. Don't necessarily dismiss it out of hand, per Professor Larkin.
Yeah. I'm not going to mention kidney cancer.
You can.
Well, it's
What's
just
happening there?
well, the point is for adjuvant combination in kidney cancer. I declare my conflict of interest. The trial that we did, Rampart, is positive, but at the time of writing, we haven't presented the data for durvalumab monotherapy in terms of contribution of components. So ASCO 26. There we go. Bit of an advert.
Are you telling me not to publish this episode before ASCO 26?
I don't know. I didn't think I said
Hold
anything
on.
about the result, so I think it's fine
Okay.
either way.
Okay, good. Well, thanks for this. If there's any other teaching points you have, speak now.
No, don't think so.
Okay. Okay, good.
We're good.
Well, thanks. Yeah, thanks.